Hi, listeners.
Hello. Welcome to the MedInsights Unleashed podcast
With your hosts,
Z.
and John. Good morning, Zara. How are you?
Good morning, John. I'm doing well. It's early for me. It's 6:15 in the morning, but I'm awake, slowly caffeinating.
I'm full of beans today, and I haven't had coffee either. I'm very privileged to Professor Paulo Hoff here with us today. Professor Hoff is at the University of São Paulo, Brazil, and has been a leading researcher in colorectal cancer. He has been involved with all the major products that have been developed for colorectal cancers. We're going to be doing 2 episodes with Paulo. The first one is going to be about rectal cancer and rectal preservation and the work and research that he's doing in that particular field. And then on the second episode, we'll be talking about colorectal cancer and specifically about immunotherapy. So, Paulo, if you'd like to introduce yourself to our listeners, please go ahead. Thank you.
Thank you.
Okay, thank you, John. Thank you, Zara. It's great to be with you. I'm a clinical oncologist, and I've had, as you said, my professional life dedicated to research in the area of the colorectal cancer, especially. Since I came back to Brazil, we expanded a little bit more into GI tumors in general, but colorectal remains a passion, and very happy to be able to be here today talking about this subject with you guys.
I will say, I think this is our first episode topic related to colorectal cancer. So, Dr. Hoff, we are very honored and privileged.
Incidence, actually, I was looking at, Paulo, it's around about 2 million people globally. It's the third largest cancer in the world. And they're predicting that by 2045 to go up to well over 3 million people. Interesting enough, the diagnosis is becoming more and more in younger people. My question to you is if you could give us insights into rectal cancer and pathway to treatment from first diagnosed. And then your subject is really on rectal preservation, which is really outstanding research.
Okay, I think it's a great way to start this. Perhaps we could talk a little bit about the epidemiology. As you said, colorectal cancer has been rising worldwide. In our country here in Brazil is the same. Right now, it's actually among women the second cancer cause. If we exclude the normal skin cancers, then you have breast, and colorectal has surpassed all the other tumors. So very, very important. For males here, it's the third, but rapidly approaching the second position. And we've seen this increase worldwide, and perhaps more concerning, we've seen the incidence rising in younger patients. We used to say that it was a disease that used to affect people over 60 usually, and our screening process started at age 50, because we thought it would be for the regular patient enough to protect and mitigate the risk of dying from colorectal cancer. But over the last decade, we've seen a dramatic increase in the number of patients who are below the age 50 with the colorectal cancer, seen here in Brazil and in Europe and the United States, to the point that right now, most of the agencies involved in planning for cancer screening have recommended that we drop the age where we start doing the screening for colorectal cancer to 45 years of age, which is very relevant.
Okay, so 45 years of age for screening. And what does that screening diagnostic test look like? Is it colonoscopy typically?
There are several options available, but the one that's considered the gold standard is the colonoscopy. However, if we were to offer colonoscopy to every single human being above the age 45, the system would not be able to cope with that. So when we talk about healthcare systems, probably the use of the fecal cord blood and the makes much more sense. As if you check for or put blood in the stools once a year, you drop your risk of dying of colorectal cancer by at least 30%. And of course, if you have a positive test, then you do the colonoscopy. There is a recent development, which is the blood-based biopsies for colorectal cancer. And in the future, it's possible that we have this additional option of doing blood-based testing to see if the patient has a colorectal cancer. The problem with that, with the liquid biopsy, is that currently it's directed to patients with cancer. And when we talk about fecal cord blood and we talk about colonoscopies, we actually also looking for people with polyps and doing the removal of the lesions before they have the chance to become cancerous. So not exactly the same, the liquid biopsy, to the other means that we have to prevent colorectal cancer.
If a patient has familial history of cancer, then would the screening be different? Meaning, would they, skip the fecal occult blood and go straight to a colonoscopy, or no, if there's familial history?
That's an excellent question. If the patient has a familial history, they'll fall in two categories. You have patients who have established familial syndrome, such as Lynch syndrome or familial polyposis, for instance. And those patients have to start their screening at a very early age. And we usually go most likely colonoscopies, although for polyposis, you could argue that the rectosigmoidoscopy would be just as good. But most people would prefer to do colonoscopies. But then there is a second group of patients who have a strong family history of colon cancer, but you cannot find a gene that's clearly different. For those patients, probably the rule that applies is that you start screening 10 years with an age that's 10 years younger than the youngest person in the family to have had the colon cancer. And I also, for those patients, would prefer to do colonoscopy.
What's happening out there that you believe that is driving this upswing in younger patients getting colorectal cancer?
John, that's a very good question. And the reality is that it's not only colorectal cancer. We've seen an increase in younger patients having breast cancer, gastric cancer. And yes, I think diet may have a big role here. Also, the lack of physical activity. We know that exercising has some protective effect. And unfortunately, in our society nowadays, a lot of people don't have the chance to do adequate exercising. The other point is obesity. And we're not talking about being overweight. We're talking about real obesity with your BMI over 30. It seems that people with this condition will have more inflammation and would have a higher risk of cancer as well. So probably what we're seeing here is a group of things that are acting together to increase the risk of different types of cancer.
So what happens now that a patient comes to you with either a prehistory? How does that pathway for the patient go from the time of diagnosis right through to treatment? What's the flow?
Okay, so usually the patient will come either because they have a family history and they've been doing this screening and have an incidental finding of rectal cancer, or patient comes with hematochezia, which is blood in the stools, or difficulty to have a bowel movement, or stools that have changed in shape and become thinner. And they come that they have noticed those changes, and we identify that they have a rectal cancer. When we talk about the colon, obviously it's a little bit more complex, but when we talk about the rectum, a lot of the tumors are easily palpable on the rectal exam, which is a very important part of your physical examination of the patient. Anyway, so if they come with those complaints, we would do the physical examination. We would ask for a colonoscopy. And once we identify the tumor, we proceed with staging. And luckily for us, a lot of the times the tumors are restricted to the rectum and to the colon, and you can plan a definitive treatment with a high chance of curing the patient.
It's clearly very symptomatic, unlike other cancers, which could be more quiescent. But in the case of rectal, like to what you just mentioned, it's clearly symptomatic that would kind of propel the patient to go in, and then the various diagnostic tests would then be conducted, correct?
You're absolutely correct. And That's one important thing for the audience. I mean, if you start having rectal bleeding, unexplained rectal bleeding, if you notice a significant change in the shape of your stools or the way your bowel movements happen, if that doesn't improve, you should seek medical help because it could be a sign of colorectal cancer. And like I said, in this sense, we are lucky because if you have, for example, pancreatic cancer, it takes much longer for you to diagnose because it's such a silent tumor. With colorectal, you tend to develop symptoms earlier, and that might help to have an early diagnosis.
Can you explain the staging to a patient that's listening? So what does staging mean from your perspective?
Sure. Staging is a determination of the exact extent of the tumor locally and distantly. And for rectal cancer, actually, it's very important. And it was the first time in the medical field that we had a staging system. Duke's established in the early 20th century, the first staging system for any type of cancer, it was exactly with rectal cancer. And an easy way to do is that we will try to find if the tumor is localized, if it has a spread and involved the entire organ, and if it has a spread to lymph nodes or to distant organs. And that will shape our strategy on how to best treat the patient and also have an implication on the chances of this patient getting cured or not with our treatment.
When you speak about staging, okay, so localized versus, I'll save the question around the distant kind of metastases. To your point, you want to, if it's within the rectum, then you can, save it. What are the cases where patients then need to get a bag, or a temporary ileostomy? Could you kind of walk us through that as well? Because I know that might be some of the thoughts that are going through some, listeners or patients' minds.
Yeah, that's historically the way you treated a tumor that was at the end of the bowel was removing that piece of the bowel. And a lot of times you end up with a permanent colostomy bag would be an alternative way of you having your stools eliminated. Now, nowadays, we try to avoid that as much as possible. And it has been something that we've been doing for many, many years. The entire medical field has been trying to limit incidence of the colostomy, the permanent colostomy bag. So once you have a rectal tumor, because usually that will apply mostly to rectal, not to colon. If the tumor is high enough that you have a chance to remove the piece of affected rectum and still reconnect what is left, then you can preserve. However, sometimes the tumor invades certain structures at the very end of the rectum, and it becomes very hard for you to do surgery without removing the anus and hence needing a permanent colostomy. Now, it's important to say that part of the usual treatment usually involves chemotherapy and radiation prior to surgery. And if you do that, even if you're going to reconnect later, you might need a temporary colostomy, which usually stays in place for a couple of months. And then once it's mature, it's reconnected. So we try to avoid a permanent colostomy as much as possible, but a temporary colostomy is quite common.
What does the treatment up front for that patient look like? So you mentioned chemotherapy and radiation. I'm going to have a two-part question because I usually do this. So the first part is how many cycles of the chemo and then the radiation? And then the second part is clearly there has to be the component around working closely with surgeons. So you're from the kind of the medical oncology side, and then there's going to be the surgical side. So what does the MDT or, the multidisciplinary team component look like?
Okay. When we talk about rectal cancer, the multidisciplinary team approach it's very, very important and would include the radiation oncologist, the surgical oncologist, and the medical oncologist. So you do determination of the staging, and we usually divide in 4 stages. The first one, stage 1, will be a very localized disease. And sometimes you can even treat this patient with a surgical resection only. There are several types of different approaches that can be discussed. For stage 2s and 3s, usually the treatment is multidisciplinary. And for stage 4, when you have metastases, you might treat only with chemotherapy and reserve local treatments for those patients in which symptoms are too big or there's a feel that you need to have a local treatment. Now, for stage 2s and 3s, the conventional treatment involves the use of chemotherapy combined with radiation. And historically, you would do that for about 6 weeks, give it a period of rest, and then operate the patient and follow with adjuvant chemotherapy after that. However, recently, there has been a move to bring all the chemotherapy to this interval between the chemoradiation and surgery. So there has been a movement towards what we call TNT, total neoadjuvant treatment, where you give all the chemotherapy and all the radiation therapy and leave the surgery to the very end. And this is gaining traction for different reasons, but it's something that's been done more commonly nowadays.
So when you get gaining traction, I'm assuming there's an improvement in patients' outcomes and survivals, right?
Yeah, it was hard to show a clear benefit for the chemotherapy given after the surgery, once the patient had been treated with chemoradiation. And also there was a feeling that you had all this time that you're basically waiting between the chemoradiation and surgery. Why not anticipate chemotherapy? And when you do that, what happens is that you increase the number of patients who have an excellent response. So once you give chemoradiation, you expect, in the best cases, 15-20% of the patients having what we call a complete response, meaning that when you reevaluate the patient, the cancer is gone. Now, if you do the chemoradiation and then move the chemotherapy to this interval, the complete response rate goes up. It crosses 30%. Some people claim complete response rates closer to 50%, but I would say it's over 30% consistently. So that's very important because we know that a complete response to the initial treatment is associated with better outcomes later on, and also gives a greater chance of you preserving the rectum. So for those patients in which you would need to have the rectum amputated, perhaps with a great response, with a complete response to the initial treatment, you can save the rectum. And that becomes very important.
That is.
So the propensity for that cure, in inverted commas, for that high pathological complete response rate is really important to get the diagnosis as early as possible, right? In stage 2 or stage 3.
Yeah, of course. The smallest the tumor, the easiest the treatment. And again, when you move, answering to Zara, when you move all the treatment to the pre-surgical stage, you go up by around 50% in your complete response rate, from 20 to 30%. And that increases the chance of preserving the organ. So very important.
That's amazing.
So then what happens after? So patient has received the upfront treatment therapy. They've received their surgery. It's now been determined that they have I think what John mentioned, it's important. It's a pathological complete response, right? So you're actually testing. I think it's important to highlight that, right? It's a pathological complete response. What does that mean?
A complete clinical response. Of course, to know if it's truly a complete response, you need the pathology. But now we're trying to work with ways around that. So you can use MRI, you can use PET scans, and you can use physical examination, direct physical examination of the rectum to see if you had a complete clinical response. Now, in the past, even with a complete response, we used to go ahead and operate the patient anyway as a safety measure, because there was always the fear that if you left the tissue in place, perhaps there could be some microscopic disease that was not identified and could regrow. And we know that happens. Unfortunately, we know that if you have a complete clinical response, a few patients will have a recurrence. But the majority of those patients who had a complete clinical response, that you could not find tumor anyway, the majority of those patients are cured. So if the surgical resection would require the amputation of the rectum, and you had a complete clinical response, you could discuss with the patient the possibility of preserving the rectum, accepting a little risk that the disease could come back.
Is there biomarkers or genomics that play a role in the diagnosis to improve the complete response? Are there some markers or genes that are worse than others in the rectal cancer that will either increase or decrease your opportunity for a complete response?
I would say that there are two sorts of biomarkers. Now, we look for biomarkers that would point to patients who have a greater chance of having a complete response. And we have looked into different biomarkers. None is yet completely established, but some seem to be associated with a greater risk, like RAS mutations, for example, but that's still in doubt. And then there are actually the idea of finding a biomarker for those patients who had a complete clinical response to see if it's safe not to operate on them. And here, what's being looked the most are ctDNA, fragments of tumoral DNA still circulating to see if you have viable disease left in the patient. But again, this is not being used in the day-to-day practice. This is still investigational.
Now that you kind of walked us through the surgical component, what happens as a follow-up? So do patients come, like what does that follow-up look like for that patient then?
Yeah, excellent question, because that's very important when you make your treatment plan. You already gave all the treatment that you're planning to give the patient if you give chemo, radiation, chemo, and surgery. So the patient is treated. If you had a surgical resection, the follow-up, it's usually, most of the centers would usually follow the patient every 3 months for 2 years, then every 6 months for 3 more years until you complete 5 years. That 5 years being that magic moment where we say the majority of patients who are free of disease are cured. However, if you opt to do a non-surgical treatment, you have to have a more intense follow-up, because then you have to physically look at the tumor scar, make sure that's not coming back. And you add a layer of care for those patients. So physicians and patients who opt to have rectal sparing treatment, if they opt to have preservation, they have to be more careful, especially in the first 2 years when the risk of the disease return is highest. And that's important because if the disease comes back, you still can save the patient. Most of the recurrences, those patients who had treatment the more kind of a watch and wait, follow them very closely. They'll have, if they have a recurrence, will be local, and surgical approach can save them.
What happens when that patient unfortunately may go metastatic, and what sort of treatments would they be looking at in that stage 4 scenario?
Okay, so if the patient had the surgical resection, or if the patient had, rectal sparing treatment, and we never say that we're not going to operate. We say that we'll delay, watch and wait, and operate if the disease recurs. If unfortunately one of those patients present with distant disease, distant metastasis, then of course the treatment changes. If the distant metastasis is isolated, for example, a single liver nodule, and it happened 2 years after the initial treatment, we might even opt for local treatment of this metastasis. But if the patient has metastasis happens earlier, or if it's more spread, different nodules in the liver, lung, etc., then the treatment will be systemic. Most patients would get chemotherapy. The exception nowadays being those patients who have a very specific type of colon cancer associated to microsatellite instability. Those patients, were a minority of the patients, could be treated with immunotherapy.
The question I had was around, you had mentioned, like in terms of the metastases, if a patient has distant metastases, what are the typical sites for rectal cancer for patients to develop the metastases? Is it typically the liver?
Well, liver is always a very common site for metastasis. When we talk about rectal cancer, lung becomes very significant as well because of the type of blood drainage in the area. So let's put that away. The 3 most common places where you would have a recurrence from a rectal cancer would be locally, liver, and lung. Those are the 3 main areas that you would get disease present if you have a metastasis.
And sorry, John, one more. You said local treatment, surgical or radiation, because there's distinction between the two, very different than systemic, which is chemotherapy.
Yeah. Well, if the patient had a local recurrence and had been irradiated before, the option that you have for local treatment would be surgery. Now, if the patient has a distant metastasis, for
Mm.
example, to the liver, then local treatment could be surgical or it could be ablative type of treatments with microwave or radiofrequency. And it will depend on the expertise of the center and the discussions in the multidisciplinary team to see what would be the best approach. You also could do radiation. The stereotactic extracranial radiation could be given, but it's much less common than the ablative treatments with radiofrequency, microwave, or surgical approach.
Thank you.
Perhaps something that could be said too is that although we discussed extensively doing chemoradiation, chemo surgery, there's also developments happening trying to exclude radiation to some patients. Patients with tumors that are higher or less advanced perhaps could be treated with chemotherapy and surgery. And something that's very, very interesting is the use of immunotherapy for those rare patients with rectal cancer associated to microsatellite instability. Say 15% of the colorectal cancers are caused by microsatellite instability. 85% are not, but those 15% respond extremely well to immunotherapy. And some recent work done by Andrea Cherchak, Memorial Sloan Kettering, shows that for rectal cancer, when the primary tumor is still in place, there's no metastasis, and you give immunotherapy, if the tumors were associated to microsatellite instability, you have close to 100% complete response. It might not need neither surgery nor radiation.
For those patients, for that 15%, that's incredible.
Yeah, I mean, it's very exciting. Now, the important thing is that this is another line of work, John. We're trying to see, we as medical researchers are trying to see if we find ways of getting the tumors who are not unstable, the tumors who are stable, how to make them respond to immunotherapy as well.
And before we go further or next into our segment, Dr. Hoff, I mean, you've been fantastic. I just wanted you to clarify with our listeners, what do you mean by MSI instability?
Sure. In our cells, you have a system to correct eventual mistakes on the replication of the cells. So when one cell replicates, it has to recodify millions or billions of connections in the DNA, and some mistakes will happen. So we have machinery, we have enzymes within our cells that will correct those eventual mistakes. Some patients have deficiencies in those proteins that are associated with correction, and they will form certain extra strands of DNA, which we call satellites. And those strands are associated with the development of certain kinds of tumors. So that's not very common, but it's very particular. So any tumor that has been associated to those strands, to those satellites, they're unstable, microsatellite unstable, and they tend to respond extremely well to immunotherapy. The idea behind that is that those strands, although they are codifying proteins that are not very important, those proteins are very strange, they're not common, and they form something that will activate the immune system, will alert the immune system that something not normal is going on in there.
Okay. Okay. Thank you. John, I'm handing it over to
Well,
you.
no. Well, in this segment, I just want to thank Professor Paulo Hoff for his discussion on rectal cancer. If you could give 3 or 4 major summary points regarding rectal cancer, Paulo, to the listeners, what they should be looking out for. What are your key takeaways from this session before we move to your second session on colon cancer for the listeners?
Well, I should say colorectal cancer is common. So when you're age 45, start doing your screening. If you have family members with colon cancer, talk to your physician to see what's the best age to start, which certainly will be younger than that. And pay attention to changes in your body, especially if you see blood in stools or difficulties with your bowel movements. That might be an early sign, and look for help, because colorectal cancer is a highly treatable and highly curable, especially if you detect early.
Wonderful.
Well, thank you very, very much on behalf of MedInsights Unleashed. Paulo, I can't thank you enough, and we look forward to your next session on colon cancer and the treatment and the use of immunotherapy in that treatment. So listeners, on behalf of Zara and myself, a big thank you to Paulo Hoff.
Glad to be.
MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.